papillary structures that you can appreciate over here. And this is what MTC looks like. These are the parafollicular C cells that are enlarged. And then we have situations where the biopsy comes back as indeterminate, or it shows a follicular neoplasm where you see all these follicular cells. You don't see these classic papillae formation. And that's when you see your report as, oh, it said it was indeterminate. What does that mean? That means we could not call it as a cancer, but we don't think it is benign either. So then we have a system that we use called Bethesda system, and that classifies these nodules, the biopsies of these nodules, into six sections, like you can see here, or six categories. One is non-diagnostic or unsatisfactory. That simply means they did not get enough material, so we need another biopsy. Nobody likes it. Patients don't like it, physicians don't like it either, because you have to stick patients again. And then you have Bethesda 2, which is benign, which is very clear-cut colloid nodule, nothing to worry about. Then you have Bethesda 3 and 4. In the 3 is your atypia or follicular lesion of undetermined significance, and 4 is follicular neoplasm. Now, as you can see here, it's not benign, but it is not malignant. So it's just that the picture that we get on the needle biopsy is not very clear. And when we get this report, our patients often ask us, what does this mean? This means that it's neither benign nor malignant, but this is the risk of malignancy. The risk of malignancy in somebody who has atypia or follicular lesion of undetermined significance about 6 to 18%, whereas follicular neoplasm is 10 to 40%. And if you want to consider, you could either do additional molecular testing. For example, you could send it to ThyroSeq or Afirma, or if you just don't want to deal with, you know, this diagnosis at all, you could ask for a lobectomy, because who wants to live with that doubt, right? So it's completely okay to ask for a lobectomy when you're in doubt. But at the same time, we also understand that, we don't want to undergo surgery if it's not necessary. So the molecular testing definitely helps us make a more informed choice. Bethesda 5 is when it says it's suspicious for malignancy, where it's not again very clear, but it is more likely to be malignant than not, and the risk is about 45 to 60%. If it is NIFT-P, and if it is cancerous, it's about 50 to 75%. And then you have the malignant cells where you clearly see those papillary formations, or cells which don't look like normal thyroid tissue, and that is definitely malignant. That is your 94 to 96%, up to 99%. And why is it important to understand what is what, or that will help determine what treatment you should have. Like, should you have a lobectomy or should you have a thyroidectomy? So also, the actual management, this is what they recommend, and but that's what I've highlighted here, that the actual management actually is totally up to you, the patient. Whether you want to undergo a lobectomy, a total thyroidectomy, we can only recommend, we make suggestions, but the ultimate decision would be yours. So this, like I said, is the indeterminate, which comes under, where we have to do additional testing. So to evaluate these further, these are the test options. You have ThyroSeq, you have Afirma, you have ThyGenX, Thyramere, Rosetta. Depends on whichever center you go to. They will send either to ThyroSeq or Afirma. We send to Afirma from MD Anderson. It's a good rule out test, because, when in doubt, patients want to know, is this cancer or not? Or what? I would like to rule it out, So in that situation, Afirma comes in really handy. So what does thyroid carcinoma look like, or what are the types of thyroid? So you remember we saw the follicular cells earlier, and you have the parafollicular C cells, which are below, that is your medullary thyroid cancer, that is less than 5% of your cells. But we are going to focus today on the thyroid cancers that derive from the follicular cells. That is, the 90% of those are papillary thyroid cancer, and about 5 to 10% of those are follicular thyroid cancer. Like you can see here, again, the structure is pretty clear. This is again a section of the actual thyroid gland. This is not your FNA sample, but you can see the structures here very clearly. So to understand cancer, how does this happen? Very often we get this question in our clinic. How did I get this cancer, doctor? There's no family history of cancer, or what caused it? So this is a very simplified explanation, I think, but of a very complex process. So these are the normal thyroid cancer cells, and they have genetic material in this lighter pink structure or the DNA. And then some kind of environmental exposure, either it's radiation or chemicals or toxins, it causes some alteration in the genetic material, or it leads to development of one mutation in the genetic material. Now that one mutation, okay, it's still not cancer. The body will try to fix it. But then there's continued exposure to the irritant, either radiation or chemicals. They acquire additional mutations, like you can see here. And eventually, the acquisition of these multiple mutations leads to the formation of malignant cells. And why are they malignant? Because these mutations, they stop the normal cell cycle process. That means we have cells which are growing, but once you don't need them to grow, they technically stop. But when you have these mutations, they affect the tumor suppressor genes or proto-oncogenes, that is the genetic material, which has that stop sign on the normal growth of cells. It stops it, or it modifies it in such a way that it leads to an overgrowth of cells called malignant cancer cells. So to understand the cell cycle even better, for those who want to look at the molecular aspect of it, these are the steps that undergo in the cell cycle process. So there's this receptor tyrosine kinase. I know this is a busy slide, but it's very complex and very fascinating at the same time. So in people who don't have thyroid cancer, even in thyroid cells, during the growth process, we see that the signals go from these tyrosine kinase down either of these two pathways. That is your RAS, BRAF, MEK, and ERK. And just to explain the color coding here, the green is the normal receptors. The yellow is where we tend to get mutations, excuse me, and then we have the red where you see chromosomal rearrangements or fusions. But this is the normal process. The arrows tell you the normal pathway. That means the thyroid cancer cells either grow down the RAS, BRAF, MEK, ERK pathway, or sometimes they go down the PI3 kinase pathway. So regardless of which pathway they go down through, the follicular cells can then lead to papillary carcinoma. And as they acquire more mutations, they can turn into poorly differentiated, which if it uncontrolled can turn into anaplastic. A similar process is seen with follicular adenomas, which can be benign, but sometimes they can acquire mutations where they can transition to follicular carcinoma and then eventually to poorly differentiated and anaplastic. Now, two things I would like to clarify here is not all follicular adenomas do not transform to follicular carcinoma. And when we do an FNA, we can never tell whether it's an adenoma or carcinoma because the adenoma is very well confined and you can really distinguish between the two only when you surgically remove either a lobe or the entire thyroid gland and you look at it under the microscope. So on an FNA we can never clearly tell which is which. Also, like you might have seen earlier, papillary thyroid cancer is 90% of cases, right? 85 to 90%. So not every cancer goes into poorly differentiated or anaplastic. So these are fairly rare compared to the other two. So this is the staging system that we follow. And like you can see here, it's first we go by the age. And as you can tell here that although there is M1 or M1 stands for metastatic disease, if you are younger than 55, then your stage is only stage 2. Very often we get this question again, like what stage am I? What is my prognosis like? So if you're below 55 years of age, even if you have distant metastatic disease, it's it's still a very good prognosis. That means it's not something that's going to reduce your lifespan in any way. You may have years and years with this cancer, but it won't affect your mortality. Once you cross 55, so this 55 is at the age of diagnosis. So if you were diagnosed at, say, 25 and you are 55, your stage will not change. The staging is always at diagnosis because that's when the cancer was discovered. And but if the cancer was discovered at 55 or above, then this is a very in-depth staging system, like you can tell. And if you're more than 55 and you have distant metastasis, that's where it comes under 4B, where yes, it could have a slightly worse prognosis compared to the younger population. So, what do we follow in thyroid cancer? Once the cancer is out, how do we keep a watch on it? So, we look for something called tumor markers. That is, we try to see if there's some thyroid tissue in the blood. And that's called thyroglobulin in papillary thyroid cancer and follicular thyroid cancer. These tumor markers help us to understand the disease status, but that should not be the sole reason for pursuing additional treatment or even more studies. For example, I have some patients where we see that the thyroglobulin is slightly above normal, but it is such a small microscopic point or a decimal point. It is probably correlating with microscopic tissue. And it doesn't mean that we have to pursue treatment or additional tests because we don't treat a number, we treat the cancer, we treat our patients. So let's talk about thyroglobulin and the conundrum of thyroglobulin antibodies. So we often notice that patients who have a history of autoimmune thyroid disease, like Hashimoto's or some kind of autoimmune thyroiditis, they tend to make antibodies to the thyroglobulin. So in those situations, it becomes very tricky because the thyroglobulin level itself may be undetectable, but they still have these antibodies. Antibodies are what we follow in those situations. Then you may hear us use this word called suppressed TG value and stimulated TG value. So what is suppressed TG? So you remember the first diagram I had shown you of the TSH, the TRH, and T3, T4. So what we tend to do with T3, T4 or with T4, that is your synthroid or levothyroxine, is we give it at a dose high enough to suppress TSH. And that level of TSH suppression depends on your surgical pathology. That means what did your tumor look like under the microscope. So if there's a risk that this cancer can come back, we try to be very aggressive with keeping that TSH in check because like I mentioned earlier, TSH is a thyroid stimulating hormone. So that means if you don't have your thyroid tissue, it can stimulate any microscopic thyroid cells. So we want to keep that suppressed. So that's where we give you a little bit more hormone that is than what your body would have made to keep that TSH suppressed. And that way it'll keep that TG suppressed, or TG or your thyroid tissue suppressed. Now, stimulated TG level is the level of thyroglobulin that we see when we prepare you for radioactive iodine. In some situations, we give thyrogen. At MD Anderson, we use thyrogen a lot. At some centers, they use withdrawal. What does that mean? That means withdrawal technique is when we ask you to stop all your thyroid hormone for about 6 to 8 weeks. We put you on cytomel or the T3 preparation for a few weeks. And then as we approach the date of the radioiodine treatment, we ask you to stop the T3 as well. And a recombinant TSH or thyrogen stimulation is easier and better, although it is more expensive, but largely being covered by a lot of insurances these days. The advantage of doing the recombinant TSH is you don't have to hold your thyroid hormone. A lot of patients get symptomatic when they're asked to hold the thyroid hormone, and you feel miserable. And I would hate to make anybody miserable. So when we have an option, this is recombinant, it is short acting, it does its job, and it is out of your body. It is more sensitive than suppressed TG because what we are trying to do is we are stimulating your TSH to see what happens to the thyroglobulin in the short term. So a lot of times your suppressed TG would be less than zero point 0.2 or less than 1, but when we stimulate it, we see the actual amount of disease. It may be 10 or it may be 20 or 30. So that tells us that there is some thyroid tissue in your body. But it can be a false positive when the level is indeterminate or in between your zero point 0.2 and 10. That's when it becomes a little tricky to evaluate further. So how does this look on ultrasound? So this is when you look at it in an ultrasound view, this is your trachea, and these are the two lobes of the thyroid gland, like you can see here. And you can see that they're pointing at a small, teeny tiny thyroid nodule over here, and this is a similar nodule on this side. So this is what a benign cystic nodule looks like. It is, you can see black here. That means the ultrasound waves are going through and through. So it's just colloid, very benign looking, very smooth margins. Similarly, when you look at this one, this is also benign. So you can see the margins are really smooth. It does look like a sponge inside. You see these air spaces, but these spongiform nodules are usually benign. And then you have something what we call pseudonodule. That means you can see some margins, but you don't see all the margins. And it's not a real nodule, but it's just a collection of colloid pockets put together, often seen in Hashimoto's thyroiditis. And then you have this follicular adenoma. Now, you recall I had told you earlier, we can't always tell whether this is benign or not until you have surgery. But on imaging, we can often look at the borders. You see how smooth the borders are, how regular they are. This looks like these are all thyroid follicles, and it looks very benign because it is very smooth edge, very homogeneous looking, does not look anything abnormal or glaring at you as something, oh gosh, this looks weird. Now let's take a look at how papillary thyroid cancer looks like. So in papillary thyroid cancer, you'll see there's increased blood flow. So on ultrasound, that means look very red because this is cancer over here. It's growing, so it needs more blood supply. And on the black and white view, you'll see a lot of microcalcifications over here. Then you may see some irregular borders. You remember the follicular adenoma we just saw? It had such well demarcated margins. Can you see a margin over here? I can't. And I can see some calcifications over here. And you can see that this stuff here is kind of extending below. And sometimes you may not see much at all. So, but it doesn't have a very while this is a defined margin, you can see that here there isn't a margin. It's kind of growing into the tissue. So then once we identify or suspect this is probably cancer, we do a biopsy, and then comes the next step. So your doctor may talk to you about, what do you do for depending on what the biopsy result shows. So I'm going to go from my right to your left, over here, my right to left here. That is thyroid lobectomy is offered for a nodule in the gland, which could be just an adenoma. And if you're not sure what it is, or if it's too big or causing problems, then we offer a lobectomy. Then for benign conditions called Graves' disease or diffuse toxic goiter, there is a surgical procedure called subtotal thyroidectomy where we leave some thyroid tissue back, but most of it is taken out. And then you have total thyroidectomy where, this is offered in case of thyroid cancer, where they take out the entire thyroid gland and all you can see are the parathyroid glands. These are the anatomical levels for those who want to understand our lingo that we use in our notes. We sometimes say level 3 lymph node, level 6 lymph node, level 4 lymph node, what are level 5? So this is your cricoid cartilage, this is your trachea, these are your muscles here, and this is the jugular vein, and what you can see the sternocleidomastoid here. So when we examine you or when we do an ultrasound, we are looking at all these areas to look for any abnormal lymph nodes. Now, majority of thyroid cancer, if it does go into lymph nodes, it tends to go in level 6 lymph nodes over here. So then what are we looking for in the pathology? So the thyroid cancer was diagnosed, FNA was done, they did a surgical procedure. So then under the microscope, you're looking at what type of cancer is it? First of all, is it cancer? Like for example, follicular adenoma versus carcinoma. What is the size? So even though the nodule itself on the ultrasound may be like a 4 centimeter nodule, but the actual cancer focus must be only 1 centimeter when you look at it in pathology, or if it is spread outside, maybe 5.5 centimeter. Then we are trying to see whether it is unifocal versus multifocal. That means is it just staying inside on one lobe or is it in multiple areas? If there's extrathyroidal extension, that means is it going into the muscles or nerves? If there's some kind of lymphovascular invasion, which tells us that there's a possibility it's going into the lymph nodes. And then whether the margins are involved, that is, if the surgical margin, that is where the surgeon operated, was there some tumor tissue extending into that or was it within the surgical area? And then, of course, they will be doing some lymph node sampling or lymph nodes that they take out by dissection, and they report the location, that is right or left, level, and what level it was, what size it was, and was there any extranodal extension. What that means is, was the cancer spreading outside the lymph node? So based on our pathology, we determine whether we would do radioactive iodine, and that is what I'm coming to next. That's your iodine 131. The physical half-life of that is 8 days, and an effective half-life in the living body is about 7.6 days. And what does this radioiodine do? It emits two types of particles. The beta particles, which are actually used for treatment, that is, they destroy these residual thyroid cells. But the diagnostic scan that we do is with the gamma particles, which is usually used for diagnosis. And this is available as sodium iodide, which is either a gelatin capsule or a solution. So very often colloquially we may hear people say, oh, you'll have surgery followed by radiation. So this radiation is unlike the external beam radiation that is used in other cancers. We also use external beam in certain types of thyroid cancer, but not routinely for, low risk papillary thyroid cancer. So let's go into a little bit of history. I find history really fascinating. So this iodine 131 was first produced from tellurium from cyclotron at UC Berkeley, but it was first used only in the 1940s for treating thyrotoxicosis. And what they found was these thyrotoxic patients, they're making a lot of thyroid hormone for which they need iodine. So when you give a radioactive iodine, that is taken up by this highly active thyroid, but eventually the gland gets saturated and it, takes up all this radioiodine, but then that actually leads to shutting down the thyroid gland. And then there were a lot of papers which came out in 1946, which showed that, hey, you could use iodine 131 in treatment of hyperthyroidism. And then they found out, and they published this paper in 1949, where radioiodine was used for treatment of metastatic cancer. So this was excuse me, this was when he was first diagnosed with thyroid cancer and how he looked after treatment. That means he received 4 doses of radioactive iodine, and that led to curing him of thyroid cancer. So then it became increasingly used for the treatment of thyroid cancers. And this is the original targeted therapy. I'm sure you've heard about, oh, you can use targeted therapies in thyroid cancer. There's so many of those, but this was the first one and a very novel one, and we still use it. So what are the considerations? One, you have to follow a low iodine diet. Before that, your doctor will tell you to do it either for 10 days or 2 weeks. And then we talked about withdrawal versus stimulated thyrogen earlier. Then there is empiric dosing versus dosimetry. So usually if it's your first time getting radioiodine, your endocrinologist or oncologist will speak with the nuclear medicine doctor and come up with a dose based on what was the diagnostic scan looking like what did it show, how much was the uptake, etc. And then we have dosimetry. So suppose you've received 1 or 2 doses of radioiodine already, and now you're on your third or fourth dose, then it's good to ask your doctor for dosimetry, because this is an estimate of what is the safest dose your body can tolerate of radioiodine. So they look at your bone marrow, they look at vital structures to see how much it can handle and then recommend a dose. Now, the treatment with radioiodine can be either inpatient or outpatient. Mostly, it is an outpatient treatment. In some situations where we are using high doses, very high doses, we do admit patients and then give them a radioactive iodine. Radioactive iodine is done for both diagnostic scan as well as post-treatment scan. Uh, in order to discuss risks versus benefits, you want to discuss this with your doctor to see whether you truly need it and what are the risks. So historically, they used to use a lot of high dose of radioiodine, but we are getting better with it these days. But in terms of adverse events or risks, there was always a risk of dry mouth, affecting your bone. It would also affect your eyes, so dry eyes. You would have some pain swallowing sometimes after the radioiodine. And with prolonged use of radioiodine, and I will be talking about this more in my next talk about why we don't do too many doses of radioiodine anymore, but we see if you keep getting more and more radioiodine, you're at risk for other cancers, for example, lymphoma, leukemia. And radioiodine is largely used in the treatment of distant metastasis, particularly lung metastasis. So here are some shots or pictures of the diagnostic and treatment scans. These are some iodine 131 scans. You can see here it's lighting up very nicely. You can appreciate this is a person. There's some disease in the neck, but there is the lungs which light up. And here you can tell this person has a lot of metastatic disease because they have in the neck. They even have something in their skull, in the lungs. And then here you can't really appreciate much other than maybe something, if you have to imagine over here. But if you look at this closely, a negative scan may not mean there is no cancer. It just means that that cancer is not taking up iodine. So sometimes we still have to give a treatment dose and we may see it on the post-treatment scan. So this is why we do a diagnostic scan, but we look at the stimulated thyroglobulin. So if your diagnostic scan was negative, but the stimulated thyroglobulin shot up to about 10 or 20, very clearly telling us, no, there is something in there, we are just not picking up on diagnostic scan. And then we go ahead with treatment, and this is what we see. The post-therapy scan may show disease. Now, why do we see this difference? Why don't we see it on the diagnostic scan? Because when we do a diagnostic scan, we give a very low dose of radioiodine just to see where the tracer is going. In those situations, you may see something light up in the neck, as my pictures that I showed earlier.
Are you there?
Go with the post-therapy scan.
Oh, there we go.
Can you hear me?
Yes, go ahead. Thank you.
Sorry. Okay. Uh, I thought I lost you all. Okay, so then we have the SPECT-CT imaging. So what is the SPECT-CT? So the CT scan that is done along with your treatment or the post-therapy scan uh, tells us like if there was something that lit up on your scan, where did it light up? Like you can see this example where there was a lung nodule, it lit up over here, but the SPECT-CT scan will show you exactly. So it basically tells you the structural component which correlates with what showed up there. So similarly, up here in the higher part of the neck, you can see that this is right below the jaw and it lit up. So it tells us the anatomical correlate or the structural component of what lit up. And then we have the PET-CT. Now, PET-CT is not very commonly used in your low-risk thyroid cancer, but sometimes your doctor may ask for it. So what does the PET do? So PET or FDG-PET stands for fluorodeoxyglucose positron emission tomography. So what they do is they give you low dose radioactive glucose that is given IV. And the principle is that the areas of cancer are usually more active than surrounding tissue. And that can help to localize disease when it's not very clear with other modalities. And this can also help to characterize the disease and is a prognostic indicator. So what does this mean in simple English? So the cancer cells that are very active, you need food to be active, right? So this glucose that is radio labeled will be taken up by these cancer cells very avidly. So you see that over here, you can see these areas, they are taking it up very avidly. But the rest of the tissue, which is not as active as cancer cells, is not lighting up over here. Now this is the bladder. This is the kidney, and this is the contrast going through the kidney, and it will go into the bladder. So sometimes you may see this light up. You can see that this is your liver. This is also lighting up, but it's not as bright as these cancer areas because the liver will be active, the heart will be active, the brain, those are always active. But the cancer cells tend to stand out. Now, this is also important to know that we don't do this routinely for papillary thyroid cancer because, in general, papillary thyroid cancer is a very slow growing cancer. So, although these cancer cells may be active, they are not actively growing on a day-to-day basis. So, sometimes you may get a negative PET-CT. So, just because it is negative doesn't mean you don't have cancer. It just tells you that it's not actively taking up that glucose. So this is a very good example of that. So you see that you don't see anything here. So the yellow stuff that you saw earlier, the bright stuff, you don't see here. But when you look at the CT component of it, you can actually identify some disease, right? So just because it's not FDG active doesn't mean you don't have disease, but in a way it's not growing rapidly. So it also tells us that it's there. We need to operate on it when it is safe to do so. But at the same time, it's not growing rapidly, so it's not threatening your adjacent structures in a big way. So that's all I have for the basics of thyroid cancer diagnosis and treatments. And I'm happy to take any questions. I'm sure there might be some.
Yeah, so
Yeah.
you got there in the bottom with all the words, the 95% and the 5%. What's the one carcinomas?
Yes, carcinomas, that's the 5%.
What is what is that? What is carcinomas?
Carcinoma means cancer.
Okay.
What is benign nodules is that you just have a lump on the thyroid gland, like you can see here, and majority of them are benign. But when we use the word carcinoma, it is a scientific term for cancer.
Ah, gotcha.
Yes.
What is anaplastic?
So anaplastic, and there is more details in my next talk, but anaplastic thyroid cancer is what I actually treat also. It's a condition where these tumor cells are growing very rapidly, so rapidly that there is no time to differentiate into papillary or follicular or Hürthle cell. Those are undifferentiated cells. That means they're just growing so rapidly that most patients present with large thyroid glands or large nodules, which sometimes are compressing the airways, but they are very rare.
So what is papillary? That's what my wife has. Like, I understand that it is a type of cancer, but like,
So papillary is, so this is the colloid nodule. So papillary, like you can see here, these are where you have papillae. Papillae are like finger-like structures. And you can see that these are, these undulating structures that you see. These are
okay,
papillae. And it's not like a sheet of cells. Like here in a benign thyroid nodule, you're seeing these sheets of cells. Here you're seeing these papillae or, structures under the microscope, which is, excuse me, not normally, that's not the normal structure. So that's why we call it papillary thyroid cancer.
so papillary is a kind of a word meaning finger-like fingers?
Yes, like papillae, yeah. So if you actually look at the term, it's like finger-like processes, So um, it's basically not like a sheet-like structure that you see under the microscope, but under the microscope, they look like these filamentous or these, like
Okay.
fingers, basically. So it's what it looks like under the microscope. That's what we are describing over here as this is papillary or this is follicular, etc.
Okay, thanks.
Sure. I hope that answered your question. In your next talk, will you explain what the follow-up is for Hürthle cell cancer? So Hürthle cell cancer, the follow-up, so it really depends on, whether this is something which is still there in your neck. That means if you've had a good surgery, you don't need a follow-up sooner than 6 months. But if there is a concern that there is distant metastasis or if it is spreading outside of your thyroid, then your doctor may want to do it either 3 to 6 months. So thyroid was removed. So okay, so thyroid was removed. So why does it keep going? Okay, so there are two questions in the chat, and I apologize. It just opened up all the windows for me. So there is a question about follicular cancer and thyroid removed. Why does it keep going back? And then there's another question. Thyroid was removed, so the follow-up. So the thing is, you do take out the big thyroid gland that you see. The surgeon does an excellent job of taking it out. But there's always a chance that there are some microscopic cells still remaining in there. You can't see them because they are so tiny. So why does it keep coming back or why? So that is where the molecular testing is important. That's where we do what my next talk is covering is the advanced thyroid cancer that we try to understand that better by doing some tests on your tumor and we tell you is this going to come back or not. So in Hürthle cell or oncocytic thyroid cancer, coming to that question, what is the follow-up that we do? The follow-up is very similar to papillary or in general, Hürthle cell comes in a differentiated thyroid cancer. So the follow-up is essentially depends on what kind of surgery you had, what they saw in the surgery. That means if you had a total thyroidectomy versus lobectomy. The fact that a lobectomy was done, the surgeon felt confident that this cancer was very confined to one particular lobe, and it was most likely covered. When you look at a surgical pathology, that gives you that confirmation whether it was confined to one part of the thyroid gland or whether it was extending into the other lobe or was it extending into the muscle. So if it had any of those features, then your surgeon may bring you back for a sooner follow-up and may do a completion thyroidectomy. That means they will take out the entire thyroid gland. Or if the risk of doing a surgery is going to be very high, like for example, in some patients, the tumor is going into their vocal cord, it's causing hoarseness, or the vocal cord is out. So if they do another surgery, it can damage the other vocal cord. So in that situation, the surgeon may say, it's not a good idea to go back in again. I don't want to hurt you or do more damage. We can watch this closely. So in most cases, the follow-up is every 6 months. And what is done in a follow-up appointment is definitely an ultrasound. One needs a very good comprehensive ultrasound to look at the thyroid bed area, to look at the lymph nodes. And if you recall, those lymph nodes in the neck or the areas that had shown level 1 to 6, those are the areas where the cancer can go, and we want to make sure that nothing new is showing up there. So your follow-up should involve a very good comprehensive ultrasound. A lot of times, some of my patients who come from outside and are referred to us, they will tell me that their ultrasound only focused on the thyroid bed area. That's where the surgical scar is, and that's it. That's not what we want. We want them to look everywhere in the neck. That is one. And the next thing that we check for is the blood work. So we check the blood to see whether the thyroglobulin is detectable, whether your TSH is where it should be, and if your TSH is where it should be, how is your free T4 doing? Is it at risk for giving you some side effects? Because like I said earlier, we do give thyroid hormones slightly larger doses than what your body would have made to keep that cancer in check. So we look at those values, and we'll obviously talk to you and see how you're doing, how you're feeling. Your follow-up should also involve a good neck exam by a doctor. So essentially, three things. One is a good neck exam by a doctor, blood work to look at your thyroid function and thyroglobulin. And third thing is a neck ultrasound, a good neck ultrasound to see if there is anything looking suspicious in there. I hope that answers your question.
So you just mentioned something about levels 1 through 6.
Yeah.
What is that?
So those are the levels that we show you this. So let me pull that slide up for you so you can appreciate what I'm talking about. Here, right? So this is a person's neck. This is the neck. This is the side of the neck. You see, this is the chin. This is the jawline. These are the ears here. And we don't appreciate all this from outside because there's a skin covering it. But when you peel off the skin, anatomically, when you look inside, what lies inside the neck? So the neck is divided into sections or parts of the neck, which we call levels. So the level 1 is the highest level because it is topmost, like we start from top to down, right? So it's 1A, which is right under the chin, 1B, this is right under your jawline, and then 2A, which is under your ear, and 2B, which is right on the big muscle. You have the neck muscle. When you bend your neck right and left, you see a muscle which becomes prominent. That is called your sternocleidomastoid muscle. So these are just anatomical levels for surgeons and doctors to know where the lymph node is. So when we talk about levels, it tells us which area needs surgery. So when they say level 3 lymph node was seen, when you see your ultrasound report, or a level 6 lymph node was taken out, or when they talk about levels, they are telling us it's a uniform language that medical professionals use. And the whole reason I'm mentioning it here, I know it's medical, but for you to understand why we use these terms, because that way we are not talking about there was a 2 centimeter lymph node 2 inches away from the sternocleidomastoid. If we were used to, if you use colloquial terms like that, we won't know the 2 inches away. Is it behind the sternocleidomastoid? Is it in front of the sternocleidomastoid? Or where is it? But instead, if there's a uniform definition, level 3, I know what the doctor is talking about.
It's a map. Okay,
Or
it's a map
level
of the neck.
5B. Yes, it's a map of the neck. So those are the levels
Okay.
that. So when patients see this in the report, you're welcome to ask the doctor, and most of us will exactly show you this image and say this is what they're talking about. Does that answer it?
Yes, that's very clear. Thank you.
Sure.
What's your opinion on the neck mapping? testing?
You mean like a lymph node mapping?
After I have it done every 6 months.
Uh-huh.
And I guess it's like an ultrasound neck mapping.
Yes, absolutely. So an ultrasound surveillance that is done after surgery in most cases is where they do a comprehensive ultrasound, exactly looking at these maps, looking at this map and trying to look at each section on the map. Is there an abnormal lymph node or in level 6? Is there a lymph node in level 3? Or is there something suspicious in any of these levels? So when they do, and I absolutely am in favor of it. We do it every 6 months, even at MD Anderson, even in those people who had a small disease which was all taken out. So it's very essential for follow-up.
Thank you.
Sure. So, all right. Well, thank you for your attention. I do have another session, and I'll go through advanced thyroid cancer management. This was the basics. That talk is more relevant for either if you want to understand when does it come back, how does it come back, what does it transform to, what do we do in those situations. Hopefully, I can explain that our thought process through that talk. So thank you for your attention. I'll see you again in a little bit.